Thank you very much for the opportunity to come here and speak. So I will talk today about a topic which I call active bioceramics. And I will first give a very short kind of one slide about bioceramics and how they are delivered today for their intended use. And then talk some about the active ceramics and then some novel strategies to form an active bioceramic. And then give also some future outlooks about where I think this is heading in the future. So I focus now mostly to bone repair. I will also talk some about the spinal cord. But basically, there are three different delivery forms for bioceramics in vivo. It's the bulk material, what we as a material scientist call bulk materials. They are the scaffolds, the granules, mainly the bone void fillers then. And then there are also the class of bioceramics which are made for joint repairs and teeth repair, which I then call the load-bearing ceramics. Then there is a class of bioceramics which are the self-setting injectable and resorbable pastes for minimal invasive surgery, mainly. And then the third group of bioceramics is actually the coating of implants, where you try to, via changing the surface chemistry, also change the function of the implant or make it bioactive, for example. And in all three forms, the creation of an active implant is of great future interest. And I would like you also to observe that this does not mean per se that there is a new intended use of the implant. This will still probably be the same intended use, but with an active component in it. For example, purpose would be reduction of the future need of revision surgery, for example, for a metal implant, to have it bioactive, meaning that it will form a bond to bone and reduce the implant instability. It could be delivery of antimicrobial agents to reduce the risk of infections. It could also be improved function of an implant, or it could be for regenerative medicine purposes, which would then probably be a new intended use. Yeah, one of these that I've said already is the delivery of growth factors through the implant surfaces. And you might know from the literature there is a lot of work ongoing on deliveries of BMP2s, for example, but also recently there is a lot of papers coming out on statins, which is another active molecule which you could deliver from a surface. Here there has been less of publications coming on delivery of molecules from injectable materials. And that where I come from, that is not that difficult. Injectable ceramics, I would say, and that has to do with the high ionic strength during the setting, where the active molecules probably gets affected in some way. Then we have the large area of antimicrobial bioceramics, where you can choose different routes. One is to deliver antibiotics, other is to deliver active ions or free radicals to reduce or hinder the creation of biofilms on implants. And the third area is the regenerative bioceramics. I will talk a few words about these three. First, I will start with the surfaces. There is an interest to change or make an active metal by tailoring the surface structure. And this could be done mainly, basically through the pore system. You can create a pore system on the surface or change the chemistry for delivery of active ingredients. You can make the active ingredients bond to the surface, and you use the pore structure to be able to load enough of active substances to get a clinical effect or a high enough dose in the blood. And that could be, for example, then again, antibiotics, bone growth, or for bone bonding. And there are basically two different strategies that you can follow. Either you can go with a resorbable surface structure, or you can have a non-resorbable one. I will give two examples of these. And this is also, I just copied this from one paper which you might know about. And this is kind of in all of these, and this is more like a paper that goes more for marketing, but still, there is in all of these volumes, there are issues with coatings on metals, where new materials provide implants improved levels of performance. And one of what we have been working on quite heavily is biomimetic growth of porous hydroxyapatite coatings on top of metals. And why do we choose hydroxyapatite? Yeah, first of all, it's the same consistent as in bone. And secondly, you can make it grow biomimetically on top of a metal implant if you just tailor the surface structure of the metal implant, so you get its natural growth from a simulated body fluid. So this could either occur in vivo. We follow the route to make it on the bench or in the lab, and then we load the coating, so this type of coating with active ingredients, and then try to get a slow release in vivo. And it's a very easy deposition technique. It provides a bone-like structure, and it has an open surface. And this is how it could look like on top of a metal implant. So these sheets are hydroxyapatite grains, and the thickness of these coatings is between, let's say, 100 nanometers up to several microns, up to 10 microns. And it has a very high surface area. We have been testing this for delivery of bisphosphonates and delivery of BMP2s, and also slow release of antibiotics. And I will just show you, and this has been published in a number of papers, and this is just one example of where we have delivered antibiotics from the surface. In this case, it was tobramycin. And what we also tried to envision was a technique where you load the implant in the OR, like a fast loading, slow release technique. So you load for 10 to 15 minutes, and then we measure the release for several days. And in this case, what you see here is the inhibition of bacterial growth. So this was the reference HA coated, and these are coated plates in this case, and you see the inhibition zone of bacterial growth around the plates. And what we have measured now, these are for loading of 15 minutes, and we have a release time, in this case is 1 day, but we have measured for up to 1 week. And we still see an effect of that. So you load for 15 minutes and you get a slow release for a longer time from this type of coatings. So it's what we call a sustained release type. A new venue that we have entered a couple of years ago is to combine this with ion substituted HA. So in this first case, here, this is a pure hydroxyapatite coating, only calcium, phosphorus type of calcium coating. And in this case, we have produced, you exchange or you add some strontium to the coatings. And in this case, you also could load this with drugs, and or you get a slow release of strontium as well. And strontium is known to be effective for increasing bone strength. So we have measured the release of strontium from the coatings. We see that you have a slow release of that simultaneously, that you could have release of a drug as well. And in this case, it's a silicone hydroxyapatite. And what I would like you to pay attention to is the complete different morphologies that you can create just by tailoring the composition of the hydroxyapatites. In this case, and I will show you later, these are spheres. They're perfectly spheres, and they are hollow. For some reason, which we don't know exactly why, they form these hollow spheres at the moment. And the silicon HA form like a bundle of very, very small crystals. And you might know also from there has been a lot of publication from the group of Bill Bonfield about silicon HA as a bone void filler, where they compare that with Infuse, the BMP2, and have similar results. We have employed this as a coating and we are now exploiting that further in vivo studies. This is another route. It's a non-resorbable bioactive coating where we could tailor the pore structure of the non-resorbable coating for loading and slow release of drugs. So the other coatings will resorb and go away, and this one will stay for a very long time or during the implant lifetime. And we have done just some initial loading and release. In this case, it's also on antibiotics. And after 1 day, we have around 20% of the total loading released. So this is also an ongoing route which we're pursuing. When it comes to scaffolds and granules and drug delivery, bulk bioceramics or granules, these type of bioceramics have a natural porosity, with microporosity, which is very good for loading and slow release of drugs. But you can also tailor them to have a macroporosity for delivery of cells. But as Sam said, it's difficult to keep the cells within the pore structure. They migrate away, or usually the cell delivery from bioceramics is a difficult task. It's much easier technically to deliver active molecules. I will hook on to what Sam talked about, the spinal cord. We have been working for a number of years now on a spinal cord scaffold using bioceramics. And spinal cord injuries is still one of the areas which is very difficult to solve. And there are about 8,000 injuries in the US each year. And 45% of these are complete. And of course there is a huge cost connected to this, and there are clinically no successful treatment. So what we have been working on is a nerve graft to bridge the gap of the damaged area. And the strategy is to have a scaffold that could keep the nerve graft in a favorable position, leading them from white to gray matter. And so this is an image of one of these nerve grafts. And the strategy is then to have a regeneration of the nerves through the damaged zone. The material requirements, the natural thing would be to go for a polymer if you are to produce a nerve graft. But it's very difficult to find a polymer that is injectable, self-setting, non-toxic, and, wow. Bingo. Yeah, and it should also have a mechanical strength that is sufficient for handling during surgery. On top of that, it should be biocompatible and also be biodegradable, and it should also be probably documented some if it is to reach the clinical in a short period of time. And it should permit loading and control release of an active substance. So what we then, since I'm a bioceramics person, we have worked with a bioceramic strategy for this. And we load the scaffold with FGF. And we get a slow release of the FGF as the scaffold is resorbed. And it's resorbed after around 5 to 6 weeks in vivo. So what we have been exploiting now is we have done a number of rat studies within this where we take nerve grafts from the rats, and then we implant it. And so far, when we have the bioceramic in combination with the FGF, we get a signal going through for all the nerve, with all for all the scaffolds. And after 3 months, the scaffold is in vivo. It's totally resolved, and we currently are pursuing further studies on this. And then I would like to come back to these ion substituted HAs, which we have a big hope for. And these are just electron micrografts showing a cross section of one of these. We call them nano HA, but they are in the size of 100 to 1 micron in diameter. But they're perfectly hollow, So what you see here is are maps of calcium and phosphorus. And these are suitable for loading and release of active substances. And they also have a slow release of the ionic species in vivo. And there are in vivo studies ongoing on these as well, which are unpublished at the moment. Yes, and then these are a thing that is not currently. This is what I would like to talk now about for a few minutes. Is a project that we have ongoing on injectable bioceramics, and we currently the next step in this would be for drug delivery. Now it's not. We have focused on. You might know about the injectable bioceramics for bone wound filling maybe, and currently. The opportunity in this area, as we see that from a material side, is to reduce the price. They're very expensive. They are difficult to handle. And if you could add tissue regeneration as well, it would be a tremendous thing. And the reason why this is so difficult is that you have a powder and a liquid, and you mix it in the OR, and you transfer it to a syringe, and then you should inject. And this involves many steps, and the opportunity to make mistakes is quite. There are many opportunities to make mistakes with this, and the price is quite high. And as soon as these two, the liquid is normally water, meets the powder, the ones who work clinically might know that then the clock starts to tick, and you have a working time. And after a certain period of time, the ceramic sets. And that's it, so to say. What we have developed is a premixed cement where there is no need for mixing in the OR. You can optimize the consistency outside the OR. It's very convenient. You just open and inject. And this gives us totally new opportunity when it comes to packaging. It's just a small thing, but if you start to think of it, if you don't need a mixer and you don't need all that transfer equipment and everything, you just have the syringe, you could buy a box of syringes instead of one for each patient, and so on and so on. It never ends. And these will be very suitable for the future for delivery of active ingredients. And so this is where we are at the moment. So you have everything premixed in a syringe, and then you just inject. And it's ready to go. The future outlook. I think that from the bioceramics field, there will be much more focus on the combination of bioceramics and active ingredients. And we will move more towards the regenerative medicine field than to the pure bioceramic field, so to say. They will merge more. Of course, there is the driving force is to reach a broader patient group. And also for the coatings, I would say it would be more to reduction of the need for revision surgery. And I also think that in the future, the merging of polymers and ceramics to form novel composites, to kind of combine the two fields of polymers, which has some very good properties when it comes to the mechanics, and the ceramics, which have other very good properties. To combine those two into one would be a huge benefit for the future. So I would also like to thank both the organizers here and also all the funding providers, and including the Gothenburg Win Excellence Center by Biomet Cell. So thank you very much.